Show. All right, so like I said earlier, I am the medical director for the intensive care and cardiopulmonary services at Preston Memorial Hospital, and also the consulting pulmonologist for the Appalachian Pulmonary Health Project within the Grace and Dorney clinics. So I'm going to sort of move a little bit quickly because this was meant to be an hour presentation, but please feel free to stop me if there's any questions along the way. So we're going to be talking about chronic obstructive pulmonary disease, which affects 5% of the population, but is the third leading cause of death in the United States. And these patients have a high resource utilization, frequent clinic visits, frequent hospitalizations, and they have a need for chronic therapies, whether it's inhalers, oxygen, those sorts of things. So again, as we mentioned earlier today, COPD is characterized by airflow limitation. Usually it's caused by significant exposure to noxious particles or gases, such as cigarette smoke or other occupational exposures. Symptoms include dyspnea, cough, sputum production. Here. So you should consider the diagnosis of COPD in any patient that has dyspnea, chronic cough, sputum production, or a history of exposure to these risk factors. So dyspnea in COPD patients is progressive over time. It's worse with exercise. It's persistent versus like a dyspnea in asthma that is intermittent, usually more intermittent. Chronic cough may be productive, may produce sputum. They generally have recurrent wheezing. Any pattern of chronic sputum production can be seen in COPD patients, whether it's morning sputum production, whether it's daily. Some COPD patients do not have any sputum production. Risk factors, again, in the United States, I think the biggest one is tobacco smoke and other occupational dusts, vapors, fumes, gases. Across the world, we see smoke from home cooking, biomass fuels, and other exposures like that. So when we see a patient, we expect them to have symptoms. We expect them to have shortness of breath, chronic cough, sputum production, any combination of these three. We also expect to be able to elicit some risk factors from these patients, either an exposure to tobacco or a job that they've done or some sort of pollution they've been exposed to. But the only way to make that diagnosis of COPD is to send them for spirometry. And when we talk about the spirometry, we're expecting a post-bronchodilator FEV1 FVC of less than 70. And this confirms persistent airflow limitation. Again, symptom-wise, dyspnea is chronic and progressive. It can vary from day to day, although generally you don't see as much variability as you would in an asthma patient. But it can cause disability and anxiety in these patients. They can describe it as increased effort to breathe, heaviness in their chest, air hunger, gasping for breath. Cough is generally the first symptom that these patients present with, and they usually, oh, that's my smoker's cough. If I quit smoking, it goes away. I don't notice it. Or, I only have that when I'm at work, so I think it's something I'm exposed to, when in reality, it's generally the first symptom that appears. It may at first be intermittent and then progresses to daily, maybe productive or non-productive. Sputum production is very difficult to evaluate because patients don't always cough it up. It can be intermittent. They can have periods of flare, especially when it's associated with things like allergies or a COPD exacerbation. Keep in mind that if they do produce a large volume of sputum, that there may be some underlying bronchiectasis, which is dilation of their airways. If their sputum is purulent, they probably have an increase in their inflammatory mediators, may or may not indicate a bacterial infection. So I think, unfortunately, we tend to see that anytime somebody's got a purulent sputum, they get treated with antibiotics, but keep in mind it's not always an infection. Wheezing and chest tightness vary from day to day, from hour to hour. The wheezing can be inspiratory or expiratory. They often complain of chest tightness, which is really poorly localized because it's a generalized bronchospasm. And so it's hard to pinpoint any one area that may be in. These symptoms do not confirm or exclude the diagnosis of COPD. Keep in mind that you have to have spirometry to make that diagnosis. These are some other features that we can see in patients that have severe disease. And like Chaffee mentioned, we want to get to our COPD patients before they're having this fatigue, the weight loss, the anorexia, the cor pulmonale, depression and anxiety. We want to get to them before that so we can try and prevent these things, get them to stop smoking, and hopefully have a positive impact on their life.
How often do you see the ankle swelling? Because I tend to think of that as a cardiac thing, not a COPD thing.
Yeah, and again, that's in severe disease. I don't see that often unless there is a underlying heart disease with them.
Thank you.
Or pulmonary hypertension. I tend to see more ankle swelling. So on clinical exam, again, you want to get a good medical history. You want to find out what kind of exposures these patients have had, especially in my area. Not only is smoking big, but we've got tons of miners. We've got a bronze plant. We had lots of other factories here in the area that these patients have been exposed to for years and years. Other types of past medical history that may be contributing to the respiratory issues, including asthma, allergies, sinusitis, a history of respiratory infections, any other respiratory diseases, any family history of lung disease as well. And then what type of symptom development did they have? Did it come on as an adult? Have they had problems since they were a child, which is more indicative of asthma? And the other things that you can see listed there. Excuse me. Grace Ann mentioned, exacerbations and other symptoms, and that is very important. One of the things that we know about our COPD patients is that we have a group of patients that are exacerbators and a group of patients that are not frequent exacerbators. And those patients tend to be divided in those two groups, and they tend to stay in those two groups. So patients that have frequent exacerbations tend to be patients that will always have frequent exacerbations, and patients that have infrequent exacerbations tend to stay in that group as well. One of our hopes with pulmonary rehab is that we catch those patients that are frequent exacerbators and try and change that.
Dr. Scott, on that subject, could you speak a little bit more to what that means in terms of like mortality?
Yeah, so when we talk about frequent exacerbations and in the classification of COPD, they have it divided up into 0 to 1 exacerbations in the last year or 2 or more. So our frequent exacerbators are going to have 2 exacerbations or more over the last year, or 1 exacerbation that landed them in the hospital. And so as in terms of mortality, the more frequently you have an exacerbation, the higher your risk of mortality. I don't have those numbers at my fingers, but more frequent exacerbations tend to cause a decrease in overall function. Your FEV1 drops with every subsequent exacerbation. You don't necessarily recover to your baseline FEV1 upon discharge from the hospital. You're more likely to be readmitted to the hospital within 60 days of an exacerbation, and which will then just bring your FEV1 down further. So the mortality in those frequent exacerbators is much more significant than in the non-frequent exacerbators. Bullet point number 3 on this slide is you also want to find out how this disease impacts the patient's life. And this is that symptom portion of our COPD diagnosis. Are they missing work? Are they not able to get out and go to the grocery store? Do they participate in family activities, and depression, anxiety, their well-being, sexual activity? All of those things really impact a person's life. And the more we can do to change those impacts, I think the better the patient will do. You also need to find out what kind of support they have available to them, especially in some of our older patients who don't drive anymore. Can they get to pulmonary rehab and those sorts of things? And then what can we do to reduce their risk factors, such as, is it time to retire? Is it time to quit smoking? Can we find an alternative fuel source for some of these patients? Talk to their family members about not smoking in the house, those sorts of things. Physical exam is rarely diagnostic. You really don't see many changes on exam. You may notice diminished breath sounds. You may notice some wheezing, but really you're not going to see those signs unless there's a significant impairment of lung function. However, keep in mind that absence of these physical signs does not mean that they don't have COPD. So spirometry is going to be the most reproducible and objective measure of airflow limitation. It's non-invasive. Spirometry, at least, is readily available, and that's one of the goals of our clinics, is to make sure that there is high quality spirometry available. Peak expiratory flow is also readily available, probably more readily available than spirometry, but is not specific for COPD. So on the diagrams at the bottom, the one on the left shows a normal FEV1 and FVC. On the right, you see obstructive disease. You can see the red line shows the normal, and then the white line there shows obstructive. So you have a decrease in your lung volume versus on the left where you had an FEV1 of 4 liters, which is the forced expiratory volume in 1 second, is 4 liters. In the patient with obstructive disease, you have 1.8 liters, which is a significant decrease. This patient also had a decrease in their FVC from 5 liters to 3.2 liters, and their overall ratio went from normal at 0.8 to obstructive ratio of 0.56. Again, your post-bronchodilator ratio should be greater than 0.7. If it's less than 0.7, that would be indicative of COPD. Because of this fixed ratio, you may see more frequent diagnosis of COPD made in the elderly. And this is actually why some of the more recent guidelines have suggested using the lower limit of normal versus the fixed ratio of 0.7. And that would, so using this fixed ratio would also result in a less frequent diagnosis in people that were less than 45 years of age. And so for years, I don't think we saw a lot of COPD in patients that were less than 45 years of age, but with people starting smoking at age 5 or 6, with occupational exposure starting right out of high school or even earlier, we are seeing patients that are under 45 that are having these exposures and are developing COPD at a younger age. So using, again, the lower limit of normal, which is based on similar patients of age, race, and height. They develop this lower limit of normal, which may be a more accurate way to diagnose and to look. The risk of misdiagnosis and overtreatment of individual patients is low. Again, because with the newer guidelines, spirometry is only one parameter for establishing a diagnosis of COPD. And then there are some studies that show that abnormal lung function identifies a subgroup of smokers that are at an increased risk of lung cancer. And those are the ones with COPD changes already noted on their spirometry.
Yeah, that's interesting to me.
And I'd have to go back and get that reference. Like I said, I put this together a year ago.
Yeah, no, we're so happy that you're carrying it.
Do you think that's just an indicator of tobacco dose, or do you think that it's some other magical influence?
I think that tobacco dose, but then also I think there's other environmental factors that cause these patients to be more susceptible to COPD and likely more susceptible to lung cancer as well. So I think it's probably a mixture of both. So as far as assessment of these patients, our goals are to determine the level of airflow limitation, to determine how this impacts the patient's health status, to determine their risk of future events such as exacerbations, hospital admissions, or death, and then to guide future therapies. Talked about that. So this is what I had mentioned we were previously using to diagnose airflow limitations and to give them a diagnosis and a stage of COPD. And it was strictly based on spirometry. And so we have patients with an FEV1 FVC of less than 70. And then based on that, we look at their FEV1. And anything 80 or above is considered mild. And this is what we saw in the third patient, I believe, that we looked at today. Moderate would be 50 to 80, severe 30 to 50, and then very severe less than 30. And this is based on their post-bronchodilator FEV1. And we still use this in our COPD diagnosis, but it's not the only factor that we use.
You mentioned earlier switching to lower limit of normal instead of the fixed ratio of 70. Is that becoming a thing, or is that just a kind of something that people are thinking about for the future?
So in my fellowship training, we did use the lower limit of normal. That's what we used as our, to determine, as opposed to this fixed ratio. But not all PFT labs are giving the lower limit of normal. So I think in the absence of lower limit of normal, using this fixed ratio is acceptable.
Okay, thank you.
I think in primary care too, a lot of times they use a fixed ratio. Just they're managing so many other things.
Yes. So in addition to looking at the severity of airflow, we also want to look at the assessment of their symptoms. And there are a couple of scales that we use on a regular basis. The first one is the Modified British Research Council Questionnaire, which is the MMRC, which is a little bit more detailed. The other one that we use is the COPD assessment test, the CAT score, which is a one question that basically asks how your breathing is compared to others of the same age. There are some other more comprehensive assessments, like the St. George's Respiratory Questionnaire or the Chronic Respiratory Questionnaire, that are extremely complex. They take a lot of time to complete and is used more for research purposes or to establish a baseline, for example, at the beginning and at the end of a pulmonary, rehabilitation program. But for a day-to-day thing for me to do in my clinic or to do in the pulmonary function lab, the COPD assessment test or the MMRC are much more appropriate.
The Dartmouth Coop is really good too.
Yes, yeah, and I didn't put that one on here. So this is the MMRC, and it the MMRC is the one question, and the CAT is the multi-question here. So the MMRC basically, again, asks how breathless you are when you're out doing things. So not trouble with breathlessness except with strenuous exercise, all the way up to number 4 is too breathless to leave the house or breathless when undressing or dressing. And 0, I believe it's 0 to 1, and I think I get into this in a later slide, is a lower symptomatic versus 2, 3, or 4 is higher symptoms. And then as far as the COPD assessment test, the patients answer each of these questions, and based on these 8 questions, which talk about symptoms such as coughing, mucus production, chest tightness, breathlessness, limitations to activities. The next one has to do with leaving the house, and how confident they are when they leave the house, that they're not going to have any problems. I sleep soundly, and then energy. And based on that, they are given a score from 0 to 40. with 0 being less symptomatic and 40 being the most symptomatic. Excuse me. I'm going to arrow forward and see if they, what I have. So again, for the MMRC, 0 to 1 is considered less symptoms versus an MMRC of 2 or greater is considered more symptoms. And 10 or less in the cat is considered low symptoms versus 10 or more. Back here. So in addition to symptoms, we want to talk about exacerbation risk. An exacerbation is an acute worsening of respiratory symptoms that results in the patient needing additional therapy. A mild exacerbation can be treated with an increase in their short-acting bronchodilators. Moderate is treated with short-acting bronchodilators plus antibiotics or oral corticosteroids, and severe requires visits to the hospital or the emergency department. And again, the best predictor of frequent exacerbations, 2 or more a year, is a history of frequent exacerbations. And again, as their airflow limitation deteriorates, patients have increased exacerbation, increased risk of hospitalization and death. Other studies have looked at the blood eosinophil count, and patients with more exacerbations tend to have a higher blood eosinophil count. And that was in patients that are treated with long-acting beta agonists. They suggest that the eosinophils are a biomarker of exacerbation risk, and also that the eosinophils can predict the effects of inhaled corticosteroids on patients to prevent exacerbations. We look at comorbidities because these do influence the patient's mortality and their hospitalizations. COPD may actually increase their risk for having other diseases and having exacerbations of those diseases. But in addition to that, COPD itself has other extrapulmonary effects that we see, things like weight loss, nutritional abnormalities, and skeletal muscle dysfunction, which again is why pulmonary rehab comes into play and is such an important part of treating these patients. So the revised combined COPD assessment, again, the previous assessment consisted of gold staging only, and I want to say it was in 2000 and, when did I finish my fellowship? 13 maybe, that this ABCD assessment tool, it also incorporates patient-reported outcomes like the MMRC or the CAT score, and highlighted the importance of exacerbations for treating these patients. Unfortunately, you know, it didn't really perform any better than just using the spirometry 1, 2, 3, and 4 as far as mortality prediction. And then Group D outcomes were modified by spirometry or exacerbation history, and that caused some confusion with this scale. So if you have worsening spirometry or you have more exacerbations, you're going to be put into this D group, which apparently caused some confusion. So again, instead of looking at strictly the gold classification, which is, can you see my arrow? Okay, all right, I wasn't sure if you can see that or if I'm just pointing for myself, but so previously we used gold classification, stage 1, 2, 3, and 4, based strictly on spirometry. Now we also take into consideration, like I said, the symptoms and the risk of exacerbation history. So Group A is going to be our patients with our better spirometry, very low symptoms, fewer exacerbations. Group B, they're going to have more symptoms, but their gold classification and their exacerbation history is going to be lower. Group C is going to have worsening airflow limitation, but these patients are less symptomatic. So you look at them, you look at their spirometry, and you know they've got an FEV1 of 35% predicted, but they're you know, out there exercising every day, holding down a job, not really having any problems. And then group D are going to be the patients with worsening airflow limitation, but are more symptomatic and having more frequent exacerbations. So this is, sorry, yeah, what we just talked about, just written out in a flow diagram. I think, give me 1 second, sorry. Yeah. This gets into, again, with exacerbations, the lower risk of exacerbations is 0 or 1. Higher risk is going to be 2 or more, or one, at least one that leads to a hospital admission. So again, we want to keep this airflow limitation using this FEV1 number because it does predict clinical outcomes such as mortality and hospitalization, and then also helps us to consider non-pharmacologic therapies. And this is what we addressed earlier, that unfortunately with our payer system as it is, gold stage 2, 3, or 4 is what's getting reimbursed in pulmonary rehab. Gold stage 1 is not. And so that's why this number is still important until everybody sort of gets in line with the new classification, which again, I think came out in 2013 and really isn't that new anymore. So the number provides the information regarding the severity of airflow limitation, and then the letter provides information regarding symptom burden and risk of exacerbation. And so with this refined assessment, what they're looking at is saying that a patient has, you would call somebody COPD A4. Well, yeah, A4. So this sort of changes from this classification where 4 automatically puts you in C or D to this classification where gold stage 4 meant only your COPD, and A means that you're not getting admitted to the hospital and you have low symptoms. And so it changes this classification slightly. So what this new idea is, and I haven't really seen this being used a whole lot, but this is, I think, came out just last year, is to sort of separate these two and draw a line right down the middle. So you would have two identifying factors to classify these patients. And again, you would have 1, 2, 3, or 4 based strictly on their spirometry, and then A, B, C, or D. So again, you could have somebody that has gold stage 1 COPD and would fit into any of these 4 categories. Same thing, you could have somebody with stage 4 spirometry that would fit into any of these 4 categories based on their symptoms and their hospital admissions. And so that further delineates these patients.
I hate to interrupt. It is 9 o'clock.
Sure.
I don't want to cut you off because you've been excellent, and I want to hear finishing this. Yeah.
That's okay. There's really not a ton left that we need to get through today. I think really I wanted to hit on this.
Awesome.
Dr. Seeley, you saved the day. Thank you so much.
Sorry, I feel like I rushed through, and I'm always available to answer any other questions or.
No, that was awesome. Thank you.
You're welcome.
Happy Monday, everybody.
Thank you all.